Hello, everyone. Welcome to week 2 of our psychedelic assisted psychotherapy class. Today, we'll be talking a little bit about history, and then the self of the therapist piece is more in your assignment for this week, where you are prompted to write a little paper about just like how you feel about psychedelics and any thoughts you have, any experience you have with that. Please don't feel like you have to go into great detail about that. But yeah, so let's start with the first chapter out of the textbook, A Short, Strange Trip. So, uh, this chapter focuses on LSD, not simply as a chemical substance, but as a social phenomenon. So when we say LSD has been understood as medicine, sacrament, threat, and cultural symbol, we're naming that its meaning has never been stable. In clinical settings, LSD was once viewed as a powerful psychotherapeutic tool. In spiritual context, it functioned as a sacrament. In political discourse, it became a perceived threat to social order, and culturally, it came to symbolize rebellion, danger, and loss of control. So, the second point here emphasizes that politics, publicity, and mythology, not just data, shape how drugs are understood. Media narratives, government anxieties, and cultural fears often move faster than scientific evidence. LSD's story is a clear example of this process. This leads to the discussion of criminalization. Criminalization was not the result of a scientific consensus that LSD was unsafe. Rather, it was a social response to fear, loss of authority, and moral panic. That distinction is essential. Finally, this history matters because we are currently living through another psychedelic renaissance or another wave. Without understanding how and why LSD research collapsed, we risk repeating the same mistakes under new conditions. So, the first bullet point reminds us that psychedelic experiences do not occur in isolation. They are shaped by social context, including cultural beliefs, legal status, and collective attitudes toward altered states of consciousness. Second, drug effects interact with expectations, narratives, and power. If a culture frames LSD as dangerous or immoral, that framing influences how experiences are interpreted and integrated. Power matters here. Who is allowed to define meaning and whose experiences are dismissed? The third point introduces the idea of matrix, which extends set and setting beyond the immediate environment. Matrix includes media portrayals, moral discourse, and political climate. These factors determine whether an experience is understood as healing, pathological, or criminal. Finally, integration is not only psychological, but cultural. People need social frameworks that help them make sense of what they experienced. When those frameworks are absent or hostile, integration becomes more difficult and distressing. So, first, psychedelics are not modern discoveries. Mangini emphasizes that altered states introduced by psychoactive substances have been part of the human culture for millennia. The Eleusinian mysteries, which lasted for nearly 2,000 years, are a key example. These were state sanctioned religious ceremonies in ancient Greece attended by people across social classes. The third point, bullet point, is strong evidence that the kykeon consumed during these rites likely contained psychoactive compounds. While the exact formulation is debated, the experiential descriptions strongly suggest altered states. So finally, altered states were not marginal or deviant. They were sacred civic experiences. Participation conferred social cohesion, moral insight, and existential meaning. This stands in stark contrast to modern narratives that frame psychedelics as inherently dangerous. So the first point reminds us that Europe once had its own traditions of psychoactive plant use. These were integrated into folk learning and spiritual practice. Healers, midwives, and folk practitioners were targeted during the Inquisition. These individuals often held plant knowledge and facilitated altered states. Third point here, altered states were reframed as demonic rather than sacred. This was a theological and political move, not a medical one. Finally, unlike the Americas, European psychedelic traditions were nearly erased. This historical erasure contributed to later perceptions that psychedelics were foreign, dangerous, and unprecedented. By the 19th century, Western science re encountered psychedelics through pharmacology and ethnobotany. Researchers documented substances but often failed to engage their cultural meaning. The isolation of mescaline marks the beginning of reductionism, the belief that therapeutic value lies solely in the chemical structure. So mescaline is the compound, the psychedelic compound out of the plant. Indigenous context is largely ignored, meaning that ritual, cosmology, and communal frameworks were stripped away. As a result, psychedelics were framed as chemical curiosities rather than relational medicines. Peyote functioned and still functions as a sacrament within the Native American church. Indigenous spiritual practices were criminalized even as Western researchers experimented freely with psychedelics. You can kind of liken this to people continuing to be incarcerated for cannabis, for having cannabis, even when it's largely legal, like in the states where they are held incarcerated. So religious freedom laws were applied selectively, protecting dominant religions while marginalizing indigenous ones. And finally, this legal conflict reveals racialized power dynamics. Who is allowed to access altered states legally and who is punished for doing so? The synthesis of LSD in 1943 marks one of the most important moments in the history of psychiatry. Albert Hofmann was not researching for a recreational drug. He was a pharmaceutical chemist working with a legitimate scientific institution. His discovery occurred entirely within the norms of biomedical research. Following this discovery, LSD was not restricted or hidden. Instead, it was distributed legally to researchers and clinicians, particularly through pharmaceutical channels. This is critical for you to understand. LSD entered psychiatry as a respected experimental tool, not as a countercultural substance. The fact that over 1,000 clinical papers were published between the 1950s and mid 1960s demonstrates the seriousness with which LSD was taken. These papers explored alcoholism, depression, anxiety, creativity, end of life distress, and psychosis. This volume of research is inconsistent with the later claim that LSD was too dangerous to study. At this stage, LSD was widely viewed as a therapeutic breakthrough. Many clinicians believed it offered access to dimensions of the psyche that conventional talk therapy could not reach. Here, I want to emphasize to you that the psychiatry's initial embrace of LSD was hopeful, optimistic, and grounded in clinical observation, not recklessness. As LSD entered psychiatry, there was no consensus about what it actually did. The psychomimetic model framed LSD as mimicking psychosis. In this view, LSD was valuable only insofar as it allowed psychiatrists to study mental illness. This framing implicitly positioned LSD as dangerous and pathological. The psycholytic model, by contrast, suggested that LSD loosened psychological defenses, allowing access to unconscious material. This model aligned more closely with psychoanalytic traditions and treated LSD as a therapeutic adjunct rather than a threat. The psychedelic model, meaning mind manifesting, represented a radical shift. This model suggested that LSD could reveal insight, meaning, and even spiritual understanding. Importantly, this model challenged psychiatry's authority by implying that altered states might have intrinsic value rather than merely diagnostic utility. Then, wanting to highlight this final bullet here, Language shaped legitimacy. How LSD was named determined whether it was funded, regulated, or feared. This is a recurring lesson for you and throughout this semester. Framing matters as much as findings. One of the most compelling areas of early LSD research was the treatment of chronic alcoholism, particularly in individuals who had not responded to other interventions. Researchers initially assumed that frightening or overwhelming experiences might deter drinking, but this approach failed. Instead, clinicians discovered that transformational experiences, marked by insight and emotional breakthrough, were associated with better outcomes. This was an early recognition that fear does not heal, meaning does. Researchers began to understand that insight and meaning functioned as mechanisms of change, even though these concepts did not fit neatly into biomedical models. Participants often described renewed purpose, reevaluation of life priorities, and shifts in identities. This work also led to the early recognition of set and setting, even before those terms were standardized. Clinicians learned that preparation, emotional safety, and therapist presence fundamentally shaped outcomes. This directly anticipates modern psychedelic assisted psychotherapy models. As LSD moved beyond the clinic, media attention intensified. Rather than reporting nuanced clinical findings, popular media emphasized extremes, visions, danger, rebellion, and loss of control. LSD quickly became a symbol of rebellion, especially in the context of youth movements, anti war protests, and challenges to traditional authority. At this point, LSD ceased to be evaluated primarily on scientific grounds. Celebrity use amplified both fear and fascination, turning LSD into a spectacle. This attention distorted public understanding and contributed to moral polarization. Crucially, the public narrative diverged sharply from the data. While clinical studies emphasized careful containment and therapeutic potential, media portrayals emphasized chaos and threat. This divergence set the stage for moral panic. The Harvard controversy is often oversimplified, but Mangini emphasizes its symbolic importance. Timothy Leary and Richard Alpert are not marginal figures. They were embedded within elite academic institutions. What mattered most was not simply their research, but the perception that institutional containment had broken down. Psychedelics appeared to escape the control of academic authority. This perceived irresponsibility, whether fair or not, became a narrative that delegitimized the entire field. Importantly, other researchers who practiced cautiously were swept up in the backlash. The result was a loss of academic credibility for psychedelic research as a whole. This illustrates how scientific fields can be dismantled by symbolic association rather than empirical failure. Regulatory responses to LSD did not merely increase safety standards, they restricted access so severely that research became unworkable. Investigational new drug requirements created bureaucratic barriers that few could navigate. Private therapists were excluded, eliminating many of the clinicians who had been developing effective therapeutic tools. This exclusion disproportionately affected relational and psychodynamic approaches. As regulation tightened, funding was withdrawn, signaling institutional abandonment. Without funding or access, research could not continue. The final result was that research became functionally impossible, not because LSD failed, but because systems of power withdrew legitimacy. Moral panic crystallized around highly publicized LSD-related deaths, often involving individuals with complex psychiatric histories. These cases were reduced to simple causality. LSD was blamed without attention to context, vulnerability, or pre-existing conditions. As a result, LSD was framed as inherently dangerous rather than conditionally risky. At moments of moral panic, fear overrides nuance and policy follows emotion rather than evidence. This pattern remains highly relevant today. During this period, claims emerged that LSD caused chromosomal damage, permanent insanity, and irreversible harm. Many of these claims were based on poorly designed studies or misinterpreted data. These poor studies were amplified while later corrections were largely ignored. Once fear based narratives took hold, retractions rarely receive equal attention. This asymmetry between misinformation and correction is a powerful force in public health discourse. The classification of LSD as Schedule 1 effectively declared it medically useless and dangerous. This prohibited research, cutting off scientific inquiry entirely. Ironically, underground use expanded as prohibition removed safeguards without eliminating interest. Harm reduction was eliminated, increasing risk rather than decreasing it. This paradox remains central to contemporary drug policy debates. Mangini's most profound argument is that psychedelics threatened authority, not safety. Altered consciousness challenged norms by making social rules feel constructed rather than absolute. Youth culture amplified these shifts, intensifying generational conflict. This produced epistemological instability, uncertainty about who defines truth, morality, and reality. Thus, psychedelics became a political threat, not merely a psychedelic or a pharmacological one. Despite widespread fear, millions used LSD worldwide without the catastrophic outcomes predicted. There was no epidemic of psychosis or violence contradicting dominant narratives. Many individuals reported lasting positive change, including improved well being and meaning. This exposes a profound discrepancy between narrative and data, a lesson clinicians must remember. Psychedelic experiences rarely end when the drug wears off. Subcultures and communities form to help individuals interpret and integrate experiences. These communities blended therapy, spirituality, and identity formation. Integration occurred communally, not individually. Meaning unfolded over a lifetime, not a session, a crucial insight for modern integration work. Oh, I wonder where this, oops. I think this is just like summary takeaways. Psychedelics are uniquely socially and politically vulnerable. Their fate depends on context as much as chemistry. Context determines outcomes, including legal, cultural, and relational conditions. Ethics, humility, and containment are not optional. They protect clients and the field. Finally, history must inform practice. Without historical awareness, clinicians risk repeating cycles of harm, backlash, and prohibition. So now moving on to chapter 5, talking about the history in the use of hallucinogens in psychiatric treatment. So, psychedelic assisted psychotherapy has a long clinical lineage. This is not a speculative or fringe claim. Passy, the author of this chapter, documents decades of systematic psychiatric use of hallucinogens within respected medical institutions. This matters clinically because it disrupts the idea that we are entering entirely uncharted territory. Modern psychedelic assisted psychotherapy is a revival, not an invention. What we are seeing today is not the sudden discovery of something new, but the reemergence of approaches that were once abandoned due to political, cultural, and institutional forces rather than clinical failure. And the third bullet point here emphasizes that early clinicians already identified what we now call best practices: preparation, attention to set and setting, therapist presence, integration, and patient selection were all recognized as essential decades ago. These were not late additions, they were foundational insights. And finally, today's models echo earlier successes and failures. This means we have access to historical wisdom, but only if we're willing to learn from it. So this chapter helps us practice historical humility as clinicians. So the first bullet point here clarifies that LSD, psilocybin, and MDMA were understood as facilitators to psychotherapy, not replacements for it. These substances were never conceptualized as standalone treatments in serious psychiatric work. Second, these substances intensify and restructure inner experience. That includes affect, imagery, memory, bodily sensation, and perception. This intensification can open therapeutic windows, but it can also destabilize patients if not carefully contained. So the third point here is crucial. The drugs themselves were not viewed as curative agents. Healing was not attributed to chemistry alone. This directly challenges modern narratives that focus excessively on molecules rather than meaning. Finally, psychotherapy remains central. The therapist's role before, during, and after the drug session was always considered essential. This is an explicitly relational model of care. So the first bullet point situates psychedelics within deep human history. Psychedelic substances have been used for healing, divination, and spiritual insight long before modern medicine existed. Second, these uses occurred within shamanic and religious contexts. This means altered states were not random or recreational. They were purposeful, guided, and socially sanctioned. Third, altered states were embedded in systems of meaning and community. Experiences were interpreted collectively, not pathologized individually. This communal embedding provided containment and integration. Finally, psychiatry represents a very recent adoption of these substances. Recognizing this helps prevent the arrogance of assuming Western medicine discovered psychedelics. Initially, LSD was framed as a psychotomimemic, meaning it mimicked psychosis. This framing positioned LSD as a research tool rather than a therapy. The goal was educational. Psychiatrists believed that by experiencing LSD, they could better empathize with patients diagnosed with schizophrenia. The discovery of serotonin reinforced this view by linking LSD to neurochemical models of mental illness. This, this paradigm generated a massive research effort between 1943 and 1970. LSD became one of the most studied psychoactive substances in history. Importantly, the failure of this model was empirical, not ideological. The first reason that the model failed is that LSD experiences differ fundamentally from schizophrenia. Second, LSD primarily produces visual phenomena, whereas schizophrenia is dominated by auditory hallucinations. Third, LSD does not produce the deep alienation and ego fragmentation typical of psychosis. Finally, patients themselves consistently distinguished LSD experiences from psychotic episodes. This undermined the validity of the psychotomimemic model. So, drug-assisted psychotherapy existed long before LSD. Ether, chloroform, and hashish were used to facilitate hypnosis. Barbiturates were used in narcoanalysis to access repressed material. The goal across these approaches was consistent: reduce defenses and deepen access to unconscious material. Psychedelics fit naturally into this trajectory rather than representing a radical departure. So, low doses, multiple sessions. Psycholytic therapy was designed to work gradually rather than explosively. Instead of a single overwhelming experience, patients received relatively low doses of LSD or psilocybin across many sessions. The intention was not to dissolve the ego completely, but to gently loosen psychological defenses over time. This pacing mattered clinically because it allowed patients to remain oriented, reflective, and relational during the experience. So psycholytic therapy is more, I would say, contemporarily or like almost colloquially known as microdosing. So the second bullet point emphasizes the psychoanalytic orientation of psycholytic therapy. These treatments were embedded within classical or modified psychoanalytic frameworks. Clinicians were explicitly interested in unconscious material, defense mechanisms, transference, and insight. Psychedelics were not seen as disruptive to analysis, but as tools that would deepen analytic work by accelerating access to emotionally charged material. The third bullet highlights dreamlike imagery and regression. Under psycholytic conditions, patients often experienced vivid imagery, childhood memories, symbolic scenes, and emotional regression. Importantly, these experiences were not treated as pathology. They were interpreted symbolically, much like dreams, and worked through verbally with the therapist. Regression was considered therapeutically useful when properly contained. Finally, psycholytic therapy was embedded in long-term psychotherapy. This is a crucial distinction from many contemporary models. Psychedelic sessions were not isolated events. They were woven into an ongoing therapeutic relationship. This allowed for sustained integration, repeated meaning making, and repair of relational ruptures that arose during altered states. So the first point here is the first bullet point is here to directly challenge a common misconception. Psycholytic therapy was not fringe. It was practiced at 18 European academic centers, including major psychiatric hospitals and university. This tells us that psychedelic therapy was once institutionally legitimate. Second, thousands of patients were treated using psycholytic methods. These were not anecdotal case reports or isolated experiments. This is a large-scale clinical enterprise that accumulated experience across diagnoses, personality structures, and symptom presentations. Third, the field produced hundreds of publications. These included theoretical papers, outcome studies, technical discussions, and ethical reflections. In other words, this is a mature clinical literature, not speculative enthusiasm. By the late 1960s, psycholytic therapy had become a fully developed method. It had defined indications, contraindications, dosing strategies, therapist roles, and integration practices. The fact that this entire body of work was abruptly halted should immediately raise questions for us about how clinical knowledge can be lost for non-clinical reasons. So therapist presence is essential. This cannot be overstated. In psycholytic therapy, the therapist could not be a distant observer. Patients in altered states required grounding, reassurance, and emotional attunement. Absence or neutrality could be destabilizing rather than therapeutic. Second, transference and countertransference intensified dramatically. Psychedelics amplified attachment dynamics, early relational wounds, and projections onto the therapist. Countertransference reactions were also heightened, demanding high levels of self-awareness and supervision. This led directly to the third bullet point: greater emotional demands on clinicians. Therapists were required to tolerate intense affect, ambiguity, dependence, and vulnerability, both in the patient and in themselves. This work was emotionally taxing and required maturity, not just technical skill. As a result, a more active, humane stance was required. Therapists could not hide behind technique. They had to be emotionally present, ethically grounded, and relationally responsive. This directly foreshadows contemporary psychedelic-assisted psychotherapy models that emphasize therapist authenticity and relational safety. So the first bullet point marks a clear departure from psycholytic therapy. High doses, fewer sessions. Psychedelic therapy aimed for intensity rather than gradualism. One or a few sessions were expected to catalyze major psychological change, or something that we call in the field quantum change. Second, the focus on mystical experience was explicit. Rather than working through unconscious material analytically, this model emphasized peak experiences characterized by unity, transcendence, and ineffability. Ineffability is the inability to describe in words. These experiences were believed to reorganize personality structure at a fundamental level. The third bullet names the proposed mechanism, transformation through ego dissolution. The temporary collapse of habitual self structures was thought to allow patients to re-emerge with new perspectives, values, and emotional flexibility. Finally, this model emerged primarily in North America, particularly within contexts influenced by humanistic psychology, spirituality, and counterculture. This cultural origin shaped how psychedelic therapy was framed, less analytically and more existentially. So the first point highlights that alcohol dependence was a major early target for psychedelic therapy. Many patients had failed conventional treatments and were considered hopeless cases. Second, researchers observed that mystical experiences were strongly linked to abstinence. Patients who reported profound experiences of unity, forgiveness, or existential clarity were more likely to stop drinking. This led to the third insight: meaning replaces fear based change. Early aversive approaches attempted to scare patients into sobriety, but these were largely ineffective. Psychedelic therapy worked not by fear, but by reorienting identity and purpose. Thus, spiritual insight functioned as a therapeutic mechanism. This does not mean religious indoctrination. It means that experiences of meaning, connectedness, and value restructuring played a central role in change. So the first bullet point introduces psychedelic, psychedelic therapy, which is an integrative model. Rather than choosing between psycholytic and psychedelic approaches, clinicians began combining them. Second, this meant low dose processing paired with high dose transformation. Patients might engage in multiple psycholytic sessions to build insight and relational stability, followed by a high dose session to catalyze deeper transformation. Third, these approaches were sequential and complementary, not redundant. Each addressed different layers of the psyche: developmental, relational, and existential. Passy suggests that this may represent a future direction for PAP. Many contemporary models implicitly follow this logic, even if they use different terminology. So MDMA emerged as clinicians sought gentler agents that did not produce overwhelming perceptual changes. This reflects responsiveness to patient needs, not pharmacological novelty. Second, MDMA reduces fear without perceptual distortion. Patients remain cognitively oriented while experiencing emotional safety, making it easier to approach traumatic material. Third, MDMA facilitates trust and emotional openness, particularly within the therapeutic relationship. This directly addresses core features of trauma, such as hypervigilance and avoidance. As a result, MDMA is particularly suited for trauma, where relational safety is a prerequisite for healing. MDMA was initially legal, which allowed early therapeutic exploration. When it was criminalized in 1985, therapists did not simply start working. Underground networks formed to preserve clinical knowledge. This mirrors LSD's trajectory, but with a crucial difference. Organizations like MAPS formed to support legitimate research, ensuring continuity rather than total collapse. And if I didn't say this in a prior in last week or my intro, MAPS is the Multidimensional Association for Psychedelic Studies. I think they have, I'm trying to think, because I know that they rebranded after they failed to gain FDA approval for MDMA, like Lykos, I think it was Lykos. And I don't know if they're back to MAPS, but it's all kind of under the same umbrella. The same person is the leader, like CEO, kind of uh, president of the company. This history shows how advocacy, ethics, and institutional strategy matters. Early clinicians recognized that group formats could expand access. MDMA stables emotional processes, making group work feasible rather than chaotic. Group models reduce cost and therapist burden, addressing issues like scalability. They also enhance relational learning, allowing patients to practice connection and repair in real time. Early work lacked standardized training, which contributed to some inconsistency. Self-experience was considered essential as therapists needed to understand altered states firsthand. Modern curricula are now emerging, attempting to professionalize the field. Without adequate training, backlash is likely, repeating historical collapse. So, because it's one of the most ethically important statements in this entire chapter, I will highlight that psychedelic assisted psychotherapy is not appropriate for all patients. Passy is very clear on this point, and it is one of them that is often it is one that often gets lost in contemporary enthusiasm. Psychedelics are not benign wellness tools. They are powerful amplifiers of psychological material. As clinicians, our ethical responsibility is not to expand access indiscriminately, but to discern carefully who is likely to benefit and who may be harmed. So the second bullet point follows this that ego strength matters. This is an older psychodynamic concept that deserves renewed attention in PAP. Ego strength refers to a person's capacity to maintain coherent sense of self, regulate affect, tolerate ambiguity, and reality test under stress. Psychedelics temporarily destabilize ordinary ego structures. For individuals with fragile ego organization, this destabilization can lead to confusion, dysregulation, and decompensation rather than insight. Passy emphasizes that this is not a moral judgment about patients, it is a clinical assessment issue that requires skill and humility. So the third bullet point adds some further nuance here. Trauma severity requires caution. Trauma alone is not a contraindication. In fact, trauma is one of the primary indications of contemporary PAP, but severity, complexity, and current stability matter greatly. Individuals with severe developmental trauma, dissociative tendencies, or unresolved attachment trauma may require extensive preparatory work before any psychedelic intervention is considered. Psychedelics can rapidly surface traumatic material faster than a person's nervous system can integrate it if the work is not carefully paced. So, this leads to the final bullet point that careful screening is essential. Screening is not merely a bureaucratic hurdle or a liability reduction strategy. It is a core ethical practice. Screening involves assessing psychiatric history, relational stability, coping capacity, support structures, motivations, and expectations. Passy makes it clear that many of the historical harms associated with psychedelic therapy occurred not because the substances were inherently dangerous, but because screening was inadequate or was inconsistent. As clinicians, we are responsible for containment before transformation. So, this slide invites us to think carefully about how healing occurs in psychedelic assisted psychotherapy without reducing it to a single mechanism. The first bullet highlights intensification of affect. Psychedelics reliably increase emotional intensity, things like joy, grief, fear, love, shame, often all within the same session. This intensification brings previously defended or avoided emotions into conscious awareness. Importantly, affect is not intensified randomly. It often follows relational and autobiographical themes that are already present in the person's life. The second bullet is about activation of memory and imagery. Psychedelic states are frequently marked by vivid autobiographical memories, symbolic imagery, and somatic recall. These experiences allow patients to revisit earlier experiences, sometimes pre-verbal ones, with a different level of awareness and emotional access. Passy underscores that this activation creates an opportunity for reprocessing, but only if the experience is subsequently integrated within a therapeutic relationship. So the third point moves to meaning making, new perspectives and meaning. Psychedelic experiences often reorganize how individuals understand themselves, their relationships, and their place in the world. Patients may interpret past trauma, release rigid self narratives, or adopt new values. Importantly, these shifts are not imposed by the substance. They emerge from the individual's own psyche when given the right conditions. Meaning, in this sense, that it's not an epiphenomenon, it's a primary driver for therapeutic change. Finally, the fourth bullet addresses ego dissolution linked to outcomes. Research and clinical observations suggest that experiences of ego dissolution, which is a temporary loss of rigid self boundaries, are correlated with positive outcomes, particularly when they're accompanied by feelings of safety, connection, and insight. However, Passy is careful here. Ego dissolution is not inherently therapeutic. Without preparation and integration, it can be disorganizing and frightening. The key variable is not dissolution itself, but whether the experience is metabolized into coherent psychological growth. So the last slide of this chapter functions as both a synthesis and looking forward. Um, the first bullet point notes that psycholytic and psychedelic models are converging. Historically, these approaches were treated as competing paradigms, one gradual and analytic, the other rapid and transformative. Passy argues that contemporary practice increasingly recognizes the value of both. Many modern PAP models implicitly integrate gradual preparatory work with the possibility of profound transformational experiences. This convergence reflects clinical maturity rather than theoretical purity. The second bullet looks ahead. Group therapy is likely to expand. Economic realities, access concerns, and the relational nature of healing all point toward increased use of group-based PAP models. Passy's historical overview reminds us that group formats are not experimental novelties. They were explored early and thoughtfully. Group settings also foreground relational learning, accountability, and communal integration, elements that individual therapy alone cannot always provide. The third bullet is perhaps the most important ethical takeaway. Ethical, trained use is essential. The history of psychedelic therapy shows us that the field does not collapse because substances fail, but because practice outpaces ethics, training, and containment. Passy's work is a warning as much as it is a history. Without rigorous training, supervision, and ethical restraint, the field risks repeating cycles of enthusiasm followed by backlash. The final point offers a philosophical orientation. Psychedelics are opportunities, not shortcuts. They do not replace psychological work, relational repair, or moral development. They create conditions under which those processes may occur more deeply or more quickly, but they do not guarantee wisdom, healing, or integration. So I want to invite you to hold both hope and humility as we move forward in this semester and in any, subsequent training that you have outside of this class. All right, moving to our articles. So residential psychedelics, LSD in particular, therapy for narcotic addiction, showing you like a historical publication on this from 1973. So why does this article still matter? Savage and McCabe's study is one of the very few controlled investigations of psychedelic therapy with chronic heroin addiction. Even today, substance use disorders remain one of the most challenging areas for PAP, making this study historically and clinically significant. So when I was at UAB, we studied psilocybin for cocaine use disorder, which is, to my knowledge, like the first one in this wave and potentially ever that was done. While I was at UAB, there was conversation about the possibility of applying this to heroin use disorder. And I believe that it is now happening in Wisconsin, I think at the University of Wisconsin-Madison. But it was a very scary study to embark on because heroin it's scary in terms of a high ability to overdose without proper intervention like Narcan or naloxone. So researchers were scared to take it on because if anyone died in the research study, potentially from an overdose of heroin, it could easily be politicized and attributed to psychedelics or psilocybin in particular. So the application of this in the 70s is like pretty remarkable. So just wanting to contextualize that as well. So, second, this study was conducted within correctional and parole contexts, which immediately raises questions about coercion, consent, power, and motivation. These are not peripheral issues, they are central to interpreting the findings. Third, the intervention was not LSD alone. It combined psychedelic therapy with residential containment, preparation, and aftercare. This is crucial because the authors were very explicit that outcomes cannot be attributed solely to the drug. Finally, the study raises enduring ethical and methodological questions that map directly onto contemporary PAP debates. What counts as informed consent? What role does motivation play? How do we interpret outcomes under conditions of structural constraint? The authors begin by outlining what they call a therapeutic ideal. First, they envision a treatment that is brief and broadly applicable, reflecting frustration with long term, low yield addiction treatments. Second, the goal is freedom from pharmacological dependence, not substitution. This contrasts sharply with contemporary harm reduction models. It is important to name explicitly to y'all. So, like methadone treatment, for example. Third, they emphasize restoration of social functioning, becoming law abiding, productive, relationally connected. This reflects the mid 20th century rehabilitation ethos that ties recovery to social conformity. Finally, they aim to reduce psychopathology that sustains addiction, not merely suppressing drug use. This frames addiction as relational, affective, and existential rather than purely behavioral. The authors did not arrive at psychedelic therapy arbitrarily. First, they reference prior success with alcoholism, particularly studies showing that mystical or peak experiences correlated with abstinence. Second, LSD is framed explicitly as an adjunct to psychotherapy, not a standalone cure. This aligns with earlier psycholytic and psychedelic therapy models. Third, the authors emphasize altered states and meaning, suggesting that addiction persists partly because of existential dysphoria, alienation, and despair. Finally, there is clear dissatisfaction with existing treatments, which were producing very low abstinence rates. Psychedelic therapy is framed as an experimental response to therapeutic failure, not a miracle intervention. Savage and McCabe adopt the classical definition of psychedelics as mind manifesting agents, meaning they reveal rather than insert psychological content. Second, they describe profound alterations in consciousness across sensory, affective, cognitive, and existential domains. They are not subtle experiences. Third, ego disruption is framed as a central therapeutic mechanism. When ego defenses loosen, patients may encounter material previously avoided through drug use. However, this is critical. The fourth point emphasizes that outcomes can be positive or negative. Ego dissolution without trust, preparation, or containment can lead to terror, dissociation, and despair. The drug is not inherently therapeutic. Preparation is not ancillary in this study, it's foundational. First, preparatory psychotherapy builds receptivity to the LSD experience. Patients must feel safe enough to surrender. Second, preparation establishes trust and safety. This is particularly important given the population's history of trauma, betrayal, and incarceration. Third, the authors emphasize that preparation reduces psychotomimic reactions, things like panic, paranoia, and fragmentation that resemble psychosis. Finally, preparation supports what they call adaptive regression, where ego loosening leads to insight rather than disorganization. This language directly echoes psychodynamic theory. The study population consisted of volunteer inmates which immediately complicates notions of voluntariness. The authors argue this tension directly. Second, participants were randomly assigned to treatment or control groups, strengthening internal validity relative to many studies of that era. Third, the treatment group resided in a halfway house type residential setting, which provided containment, monitoring, and structure. Finally, both groups were treated identically after discharge, allowing the authors to attribute differences primarily to the initial intervention period. This uh, so first, incarceration fundamentally limits voluntariness. Consent given under conditions of confinement cannot be equated to consent in free populations. Second, incentives were tied to parole outcomes, whether explicitly or implicitly. Many participants admitted volunteering in hopes of early release. Third, the authors explicitly acknowledge this ethical problem rather than ignoring it, which is notable for the time. However, the fourth bullet is crucial. This issue remains ethically unresolved. Contemporary PAP must grapple with similar dynamics in mandated treatment, veteran systems, and carceral settings. So let's be concrete about the intervention. First, patients completed a 4 to 6 week residential stay, which itself is a significant therapeutic container. Second, they received approximately 24 hours of preparatory psychotherapy, focused less on interpretation and more on relationship building. Third, there was one high dose LSD session lasting 10 to 12 hours. By modern standards, this dose is extremely high. Finally, post-session integration occurred before discharge. Again, this underscores that LSD was embedded in a therapeutic process, not administered in isolation. So the control condition was not no treatment. It involved an outpatient abstinence program with significant oversight. Participants underwent daily urine analysis and surveillance, which provided unusually robust outcome data. They also participated in weekly group therapy, which is consistent with the standard of care at the time. Finally, parole monitoring applied to both groups, meaning legal pressure was constant across conditions. So the primary outcome was verified abstinence, not self-report. This strengthens the credibility of findings. Follow-up occurred at 6 and 12 months, which is relatively long for addiction research. That's how long our follow-up was. No, sorry, ours was 3 and 6 months, so this was longer than ours. They also used global adjustment ratings, assessing social, occupational, and interpersonal functioning. Importantly, evaluations were conducted by independent raters, which reduced bias. So results showed higher abstinence rates in the treatment group compared to controls. These differences were statistically significant, particularly in the first year. The strongest effects occurred early, suggesting a time-limited benefit. Over time, abstinence declined, highlighting the chronic nature of addiction and the limits of single-session interventions. Overall adjustment differences were modest, which tempers overly enthusiastic interpretations. However, at the highest levels of adjustment, the treatment group showed markedly better outcomes. This suggests LSD therapy increased the probability of optimal outcomes rather than average improvement. Abstinence and adjustment were closely linked, reinforcing the author's emphasis on total abstinence as a key marker. So patient narratives are especially revealing. Heroin is described as numbing and distancing, a way to avoid self and memory. By contrast, LSD is experienced as confrontational, bringing individuals directly into contact with unresolved issues. Sorry, it's very dry in here. Patients report increased self-awareness, often painful but meaningful. The emotional intensity of LSD stands in stark contrast with the emotional anesthesia of opioids. So, starting with incomplete ego surrender, Savage and Macabre describe this case carefully because it illustrates a central limitation of psychedelic therapy. Even in the presence of a powerful substance, ego surrender cannot be forced. The patient remained partially defended, attempting to manage and control the experience rather than allowing it to unfold. This is a critical reminder that psychedelics do not override personality structure or attachment patterns, they interact with them. The second bullet point highlights persistent mistrust and control. This individual entered the session with deep mistrust of authority, of therapists, and of the process itself. That mistrust did not dissolve simply because LSD was administered. Instead, it constrained the depth of engagement. Clinically, this reminds us that trust is not created pharmacologically. It must be built relationally over time, particularly in populations with history of betrayal, incarceration, and trauma. The third bullet point points to limited therapeutic benefit. Although the patient experienced perceptual and emotional changes, these did not translate into sustained psychological reorganization. Insight occurred, but it remained largely intellectual rather than transformative. This distinction is essential for clinicians. Insight alone is not sufficient for change, particularly in addiction. Finally, the case ended with relapse and reincarceration. Savage and McCabe include this outcome deliberately, resisting the temptation to present only success stories. This relapse underscores the reality that psychedelic therapy does not inoculate against structural forces such as poverty, criminalization, and lack of support. Clinically and ethically, this case cautions us against overgeneralizing positive findings or attributing failure solely to individual resistance. In contrast, this case exemplifies that what the authors describe as a full mystical type experience. The patient reported a profound sense of unity, transcendence, and emotional release. Importantly, this experience was not merely perceptual or emotional, it was meaning saturated. The patient described it as deeply real and personally significant. So, then emphasizing profound unity and meaning. During this session, the patient experienced reconciliation with aspects of self and others that had previously been irreparably fractured. This sense of unity extended beyond the self to include others and the world more broadly. Clinically, this mirrors contemporary findings linking mystical type experiences with durable therapeutic change. So the third bullet notes sustained abstinence. Unlike the unsuccessful case, this patient maintained sobriety for a significant period following treatment. However, Savage and McCabe are careful not to frame abstinence as effortless or automatic. The patient still faced cravings and stressors, but the experience appeared to provide a new internal reference point that supported self-regulation and choice. Finally, the authors described an expanded identity. The patient no longer identified solely as an addict or a criminal, but began to see themselves as capable of moral agency, connection, and purpose. This identity shift is crucial. Addiction is not just a behavioral pattern, it is an identity structure. Psychedelic therapy appears to facilitate change most powerfully when it reorganizes how individuals understand who they are. So, first, we'll talk about peak experiences were common but not sufficient. Many participants reported intense, even mystical experiences, yet not all achieved lasting behavioral change. This challenges simplistic narratives that equate intensity with efficacy. Second, peak experiences were correlated with the best outcomes, particularly those involving complete abstinence and high levels of social adjustment. This suggests that peak experiences may open a window of opportunity for change, but they do not determine what happens next. The third bullet emphasizes that peak experiences were not universally predictive. Some individuals had profound experiences and still relapsed. This tells us that other variables such as personality structure, environmental context, social support, and ongoing therapy play decisive roles. Finally, Savage and McCabe conclude that the peak experience functions as a facilitator, not a guarantee. It creates conditions under which transformation is possible, but it does not replace the slow work of integration, habit change, and relational repair. This is one of the most clinically mature conclusions in the paper and aligns strongly with modern PAP frameworks. So the first limitation is confounded treatment components. The intervention combined residential containment, psychotherapy, LSD administration, and aftercare. While this holistic approach may be clinically sound, it makes it impossible to isolate which component produced which effects. Methodologically, this limits causal claims. Secondly, the coercive context of incarceration and parole fundamentally complicates interpretation. Even when participants volunteer, the presence of institutional power shapes motivation, compliance, and reporting. This raises enduring ethical questions about consent that remain unresolved in contemporary mandated treatment settings. The third limitation concerns a single session model. While the results were promising, addiction is a chronic, relapsing condition. A single psychedelic session, even a powerful one, may be insufficient for sustained change without ongoing support. This limitation has directly informed modern multi-session PAP protocols. Finally, the authors acknowledge cultural and racial dynamics. Most participants were Black men, while the therapists and researchers were predominantly white. These power asymmetries were not fully examined at the time, but are essential for contemporary readers to interrogate. Cultural meaning, mistrust, and historical trauma likely shaped both experiences and outcomes. So, implications. The first implication is that preparation and integration are essential. Savage and McCabe's findings reinforce that psychedelic experiences are most beneficial when carefully framed and metabolized within a therapeutic process. This insight has been repeatedly confirmed in modern trials. Second, set and setting are decisive, not peripheral. The institutional context, therapeutic relationship, and cultural narratives surrounded the experience profoundly shaped outcomes. The cultural narratives surrounding the experience profoundly shaped outcomes. This reminds us that psychedelic therapy cannot be ethically or effectively separated from its context. Third, the authors implicitly argue that ethics must lead innovation. The collapse of early psychedelic research was not due to lack of promise, but to ethical, political, and institutional failures. Contemporary PAP must prioritize ethical rigor if it is to endure. Finally, the substance alone is insufficient. LSD does not cure addiction. It facilitated experiences that, under the right conditions, supported change. This distinction guards against pharmacological reductionism and keeps psychotherapy central. So, some key takeaways here. The first takeaway is that psychedelic therapy shows promise for substance use disorders, even in highly complex populations. This study remains notable precisely because it does not exclude individuals with severe addiction histories. However, the second point is equally as important. It is not a standalone solution. Psychedelic experiences must be embedded within broader therapeutic, social, and structural supports. Third, the study reinforces that addiction is relational and existential, not merely behavioral. Psychedelic therapy appears most effective when it addresses meaning, identity, and connection rather than focusing solely on abstinence. Finally, history offers both caution and guidance. Savage and McCabe's work invites us to proceed with hope, tempered by humility. The promise is real, but so are the risks of enthusiasm that outpace ethics, training, and care. All right, our final paper here, LSD for alcoholism in 2012, a meta-analysis. So this article is important because it fundamentally reframes how we understand the early psychedelic treatment literature. For decades, LSD therapy for alcoholism was dismissed as anecdotal, poorly designed, or ideologically driven. Krebs and Johansson challenged that narrative by conducting the first quantitative meta-analysis of randomized controlled trials. The second bullet here emphasizes that this paper reassesses trials from the 1950s through the early 1970s, which is a period often caricatured as scientifically naive. What the authors show is that while imperfect, these trials were far more rigorous than they are usually given credit for. Third, the article challenges the assumption that evidence for LSD was weak or non-existent. Instead, the authors demonstrate that moderate but meaningful effects were present. and often statistically significant when trials are pooled appropriately. Finally, this paper has direct relevance to contemporary psychedelic assisted psychotherapy, particularly as we debate dosing models, durability of effects, and how to compare psychedelic interventions with standard pharmacotherapies. The authors begin by grounding the study in public health reality. Alcohol contributes an enormous global morbidity and mortality, exceeding many illicit drugs in overall harm. This is not a marginal issue. It is a central mental health challenge. Despite decades of research, existing treatments have limited effectiveness. Even evidence-based pharmacotherapies and psychosocial interventions leave many patients cycling through relapse and recovery. The third bullet highlights the relapse rates remain high, even among individuals who are motivated and engaged in treatment. This underscores that alcohol dependence is not simply a failure of willpower or compliance. As a result, the authors argue the need for a novel mechanism of change, interventions that operate differently from daily pharmacologic suppression or purely behavioral control. Historically, clinicians noticed that LSD sometimes produced unexpected benefits in alcohol-dependent patients, particularly when compared to standard care. The second bullet highlights induction of insight and motivation. Patients frequently report sudden clarity about their drinking patterns, relationships, and self-destructive cycles. Third, LSD appeared to facilitate meaning making rather than simply suppressing craving. It often reorganized how patients understood their lives, values, and purpose, dimensions strongly linked to sustained recovery. Importantly, this approach was distinct from aversive therapies, which attempted to condition fear or disgust toward alcohol. LSD therapy sought transformation rather than punishment. The core problem addressed in this article is methodological. Despite many early trials, there had been no formal quantitative meta-analysis evaluating LSD's effectiveness for alcoholism. As a result, interpretations of early findings were mixed and inconsistent, often influenced by political or cultural factors rather than data. Many individual trials were underpowered, meaning they lacked sufficient sample size to detect moderate effects, even if those effects are real or were real. By pooling data across studies, the authors aim to provide a more accurate estimate of treatment effect, separating signal from noise. The authors conducted a systematic literature search across multiple databases and time periods without language restrictions. This reduced publication and selection bias. Only randomized controlled trials were included, strengthening causal inference and excluding purely observational or anecdotal studies. Data extraction was performed independently by two reviewers, increasing reliability and minimizing interpretation or interpretive bias. Finally, the authors used a random effects meta-analysis, which assumes that treatment effects may vary across studies, a realistic assumption given differences in setting, preparation, and patient populations. Participants were adults treated for alcoholism within established treatment programs, making findings clinically relevant. All included trials used a single high dose of LSD, allowing the authors to evaluate a specific intervention model rather than a heterogeneous dosing strategy. Each trial included a control condition, sometimes using active placebo like low-dose LSD or stimulants, which strengthened internal validity. Importantly, participants with psychosis were excluded, reflecting longstanding recognition that psychedelics are contraindicated for certain psychiatric conditions. The meta-analysis ultimately included 6 randomized controlled trials. It's a modest number, but it's substantial given the era. The total sample size was 536 participants, and it's notable, particularly when compared to many modern PAP trials. Participants were predominantly male inpatients, reflecting both historical treatment demographics and limitations regarding generalizability. All trials occurred within structured treatment settings, meaning LSD was not administered in isolation, but embedded within broader therapeutic programs. LSD doses were high by any standard, often far exceeding what is used in contemporary trials. The median dose of about 500 micrograms reflects the expectation that therapeutic change required a profound subjective experience. All trials use single dose or single session administration, which is important when considering durability of effects. Crucially, LSD was embedded in psychosocial treatment, not administered as a standalone intervention. Preparation, milieu, and aftercare varied across studies, but were always present to some degree. The primary outcome was alcohol misuse, broadly defined to include consumption and consequences. Outcomes were dichotomized into improved versus not improved, which simplifies analysis but risks losing nuance. Assessment occurred at the first reported follow-up, ranging from 1 to 12 months depending on the study. Importantly, classification was conservative. Ambiguous or modest improvement was often counted as unimproved, biasing results against finding an effect. The pooled odds ratio of 1.96 indicates that participants receiving LSD were nearly twice as likely to improve compared to controls. This effect was statistically significant, with a p-value well below conventional thresholds. The number needed to treat of approximately 6 means that treating 6 patients with LSD instead of control would result in one additional improved outcome, comparable to or better than many standard medications. Importantly, heterogeneity was negligible, suggesting that effects were consistent across studies despite differences in protocol. Effects were strongest at short-term follow-up, typically 2 to 3 months after treatment. Benefits remained statistically significant at midterm follow-up around 6 months. By 12 months, effects were no longer statistically significant, indicating that benefits may diminish without continued support. This pattern suggests that LSD may initiate change, but maintenance likely requires additional intervention. Among trials reporting abstinence, LSD was associated with significantly higher abstinence rates at early follow-up. However, these effects were not sustained at later time points. This mirrors findings for alcohol misuse overall and reinforces the idea that psychedelic experiences may catalyze but not maintain behavior change on their own. Across all trials, acute adverse reactions were relatively rare. Importantly, no lasting harmful effects were reported, even with very high doses of LSD. Most adverse events involved anxiety, agitation, or confusion, often resolving with reassurance and support. These findings underscore the importance of set and setting, preparation, and interpersonal containment. Using Cochrane criteria, the authors found generally low risk of selection bias, as all trials used random assignment. Blinding was a challenge, particularly given the obvious effects of LSD, though many studies used active placebos to mitigate expectancy effects. Attrition was handled conservatively, with missing participants counted as unimproved, biasing results toward null effects. Some selective reporting was noted, particularly de-emphasis of short-term benefits in favor of later outcomes. Sensitivity analyses showed that primary findings remained significant even when excluding multiple trials. Interestingly, effects were stronger when non-blinded trials were excluded, suggesting that expectancy biases did not inflate results. Secondary outcomes were less stable, reflecting small numbers of studies with greater variability. Overall, the robustness of their primary outcomes strengthens confidence in the findings. The authors compare LSD's effectiveness to naltrexone, acamprosate, and disulfiram. I know I mispronounced all of those. Showing comparable or superior effect sizes. No, those are all like medication treatments for alcohol use disorder. Notably, LSD achieved these effects with a single dose, whereas approved medications require daily administration. This highlights a fundamentally different mechanism of action centered on experience and meaning rather than receptor blockade. These findings challenge assumptions about how psychiatric medications must work. The authors emphasize that LSD's effects likely operate through psychological mechanisms, things like insight, motivation, and meaning making. Mystical type experiences appear particularly relevant, though not universally necessary. Change often involved reframing identity, moving from alcoholic to someone capable of choice and purpose. This positions LSD as a psychological catalyst, not a maintenance medication. The authors are clear about limitations. Only 6 trials, all conducted decades ago. Historical context limits generalizability to today's diverse populations and ethical standards. Some trials provided minimal information to participants, raising consent concerns. Thus, the findings justify modern, ethically rigorous replication, not clinical implementation as is. And finally, y'all, this article supports the idea that single session psychedelic interventions can have meaningful clinical impact even months later. However, integration appears crucial for sustaining benefits beyond the acute window. Alcohol use disorder emerges as deeply meaning-based and existential, not merely compulsive. Finally, this work invites us to rethink what counts as medication in psychotherapy and to remain open but critical as PAP evolves.